All right, so in this session, we're going to talk about the intent and the principles of airway management. Why do we manage airways? What are our goals? Well, first and foremost, we want to oxygenate our patient. That's the thing that's the real emergency. Then we want to minimize the risk of aspiration. And whenever possible, we want to ventilate the patient. And ventilation, in this case, means remove excessive carbon dioxide. Now, usually that happens during whatever process it is that we're using to oxygenate the patient, but not always. And there are times when those two aren't occurring simultaneously. And as long as you're oxygenating the patient, that's the real priority. So state-of-the-art airway management is not so much about what we do, the specific techniques. It's about how we do them. This is a little reminder of what airways look like, and I gotta say that if every airway looked like this, right out in the air, cords right in your face, they'd all be easy. So the core concept of airway management is not any given skill, but it's about the decision making. Whose airway we need to manage it, how we're going to manage it, when we need to manage it, and why we're managing it in the particular way that we are. So every patient needs airway management, but many of them manage their airways on their own. However, if you determine that the patient needs an intervention from you, you need to think about what's going on as one of three types of airway management requirement. First, is there a patency threatening event? If their airway is going to be obstructed at the level of the glottis, then they need to be endotracheal intubated or have a surgical airway done. None of the other techniques are going to solve that problem. Now, fortunately, those patients are few and far between. Oftentimes, it's an oxygenation and ventilation failure. In those cases, CPAP or bag valve mask, plus or minus intubation or a blind insertion airway device, may take care or likely will take care of that problem. In a pure oxygenation failure, sometimes just adding supplemental oxygen is sufficient. Sometimes you need to add CPAP or bag valve mask. But by knowing what problem you're addressing, you can figure out the least invasive and safest way of addressing that problem. So if we think about how we've been trained over the years, the state of the art in non-invasive airway management hasn't changed a lot, but there are some key changes. It used to be everyone got oxygen. Didn't matter, you sprained your ankle, you got oxygen. Now we know that not everyone needs oxygen, and in fact it can be harmful. So we want to titrate it, trying to keep our oxygen saturations at about 94% or above, or whatever the patient's healthy baseline is. We've discovered that there is a small population of patients who benefit from medication-facilitated continuous positive airway pressure, and so sometimes we need to do that. We want to do two-person bag valve mask ventilation, and we'll talk about this more. And the mask seal should always be from the top of the head. And then finally, when you are ventilating an unresponsive patient using non-invasive techniques, you want to put in not just an oropharyngeal airway, but two nasopharyngeal airways. That gives you your best airway patency. So again, you want to make your mask seal from the top of the head so that you can lift the jaw. You want to make sure that the airway is open. With a head tilt chin lift, we can very clearly lift the jaw. If we're doing it with bag valve mask ventilation, we need to use our small ring and middle fingers to lift the mandible, and our thumb and our index finger to seal the mask to the face. And this is very awkward, and it's very easy to break the face mask seal. So it's really important, whenever possible, to do two-handed face mask seal. So you have a helper who squeezes the bag valve mask, or you use an automatic transport ventilator attached to a face mask so that you can focus entirely on sealing the mask and keeping the airway open. This is what state-of-the-art non-invasive ventilation, positive pressure ventilation looks like. Any questions, just email me. Thanks so much. Bye.